Hi, my name is Pamela Zambrano Pincay and I'm going to talk about tracheal intubation. Definition is the placement of a flexible
With the left
plastic
hand,
tube into the
insert the
trachea,
curved blade of the laryngoscope into the mouth over the right side of the tongue, displacing it to the left and upwards.
To administer certain drugs.
Advance the
It is
laryngoscope
frequently
slightly
performed in a
until the tip of the
critical
epiglottis can be
injury,
seen
ill or
posterior to the back of the
anesthetized
tongue.
Patients to facilitate
Advance the tip of the
ventilation
laryngoscope
lungs,
blade
including
into the
mechanical
vallecula
ventilation
between the
and to
epiglottis
prevent the
and the tongue.
possibility of asphyxiation or airway obstruction. Tracheal intubation. Because it is an invasive and extremely uncomfortable medical procedure, intubation is usually performed after administration of general anesthesia and a neuromuscular blocking drug. It can, however, be performed in the awake patient with local or topical anesthesia or in an emergency without any anesthesia at all. Intubation is normally facilitated by using a conventional laryngoscope, flexible fiber optic bronchoscope, or video laryngoscope to identify the glottis. Though other devices and techniques are available. Procedure. After the trachea have been
Of the
intubated,
laryngoscope pointing
a
away
balloon
from you
cup
at 45 degrees.
is typically
Lift upwards and away
inflated
to lift
just
up the
above
tongue
the
and
far
epiglottis
end of the tube
to display the
to
vocal
help
cords and
secure
the
it
laryngeal
in
opening.
place. To
With
prevent
the right
leakage
hand,
of
insert the
respiratory
endotracheal
gases
tube
and
from
to
the right-hand
protect
side
the
of the mouth,
tracheobronchial
directly
tree
between the cords,
from
and
receiving
into the trachea
undesirable
until the cuff
material
passes through the
such
cords.
as stomach acid.
The markings on the tube at the
The tube
incisors
is then
will show
secured
between
to the
21
face
and 24
or neck
centimeters
and
in the
connected to
average
a
sized
T-piece.
adult when the tube is in position.
Anesthesia breathing
Remove the
circuit,
laryngoscope
valve,
and
mask
inflate the
device,
cuff
or
with
medical-
approximately
or
15
a
mils of
mechanical
air to
ventilator.
prevent air leaking during ventilation. Attach the tube to the bag and valve apparatus and ventilate the patient with the oxygen flow on 12 to 15 liters per minute.
The most widely used route is orotracheal, in which an endotracheal tube is passed through the mouth and vocal apparatus into the trachea. In a nasotracheal procedure, an endotracheal tube is passed through the nose and vocal apparatus into the trachea. Other methods of intubation involve surgery and include the cricotirotomy, used almost exclusively in emergency circumstances, and the tracheotomy, used primarily in situations where a prolonged need for airway support is anticipated. Equipment. Laryngoscope. The vast majority of tracheal intubations involve the use of a viewing instrument of one type or another. The modern conventional laryngoscope consists of a handle containing batteries that power a light and a set of
A
interchangeable
laryngoscope
latches,
with appropriate blade,
which are
an
either
endotracheal
straight or
tube
loop.
with
This
stylet,
device is
and a 10
designed to
milliliter
allow
syringe.
the laryngoscopist
You will
to
also need
directly
a bag
view
valve
lungs.
mask attached to
Tracheotomy
oxygen,
is a
an
catheter
oral or
that
nasal
is
airway,
inserted into the
and
trachea
tape or an endotracheal
for the
tube
primary
holder.
purpose of establishing
Ensure that the equipment
and
is
maintaining
prepared
a path.
and check that the laryngoscope is
and
working and the cuff on the tube inflates and
air.
deflates properly.
It is a
Pre-oxygenate the
breathing
patient
designed
with
to
bag
be
and mask
placed into
ventilation
the airway
for up
of
to 1 minute
critical
before
injured,
attempting to
ill
intubate.
or anesthetized patients in order to perform mechanical positive pressure ventilation of the lungs and to prevent the possibility of aspiration or airway obstruction. Methods to confirm tube placement. Direct visualization as the tip of the tube passes through the glottis. Indirect visualization of the tracheal tube within the trachea using a device such as a bronchoscope. Waveform capnography has emerged as the gold standard for the confirmation of the tube placement within the trachea. With a properly positioned tracheal tube, equal bilateral breath sounds will be heard upon listening to the chest with a stethoscope, and no sound upon listening to the area over the sternum.